distribute them out to you. I hope this helps. I've tailored it to Liverpool, sort of the style that we were taught, and I've done some questions at the end as well, which is I've taken from Liverpool past papers. They put just questions that properly come up. So yeah, I'll start, and I hope this helps. Also, sorry about my really poor technology issues. I'm going to have to click through the slides because I'm not very good with technology. Okay, so what is an adverse drug reaction? So the European Medicines Agency, the EMA, defines an adverse drug reaction as a response to a medicinal product which is nauseous and unintended. So you can get type A reactions and you can get type B reactions. It's important to know the difference between type A and type B, especially for the questions that you get towards the start of your papers. They're often asked in like the population perspective bits before you actually get into your science of medicine questions. So type A reactions, these are augmented. So it's an exaggeration of a drug's normal pharmacological action. So these are dose dependent, and they're also reversible on reducing the dose of the drug or just withdrawing the treatment of the drug. So those are type A. Type B reactions, these are completely unpredictable drug reactions, so there's no dose response relationship. So these are also described as idiosyncratic and bizarre. So they're like unpredictable, basically. So an important agency to know the name of is the MHRA, so Medicines and Healthcare Products Regulatory Agency. So they are responsible for the monitoring of the safety of all medicines marketed in the UK. They encourage practitioners or any clinical staff to report all adverse drug reactions. They have a yellow card system where you should and you can report adverse drug reactions. So all drug reactions which cause significant, medically significant or harm to a patient absolutely have to be recorded through the yellow cards system. And that's in adults and children. And then you can also report adverse drug reactions for medicinal devices within the UK, so such as like the Freestyle Libre, the type 1 I think it's called a CGM, like a continuous glucose monitor. A lot of those are being reported through the yellow card system. Fake or counterfeit medicines and nicotine containing electronic cigarettes, the e-liquids, these can be reported through the yellow card system. So what does an adverse drug reaction look like? So it can present as an acute dystonia. So it's this is an involuntary contraction of muscles, and this can be continuous or intermittent, and it's where patients display like abnormal movements, abnormal postures. You can also see blood dyscrasias, so abnormal red blood cells, white blood cells, plasma, just weird looking blood films and blood results. Most popular you'd see a skin reaction, so I'll touch on this a little bit later, but there's something called the Stevens-Johnson syndrome or the toxic epidermal necrolysis. This is a full body reaction to a drug, and you can also get neuroleptic malignant syndrome. And this is also a life-threatening idiosyncratic reaction to antipsychotic drugs, where you'll get a patient will present with a fever, they'd be confused, have an altered mental status, their muscles will be really rigid, and they'll also have a abnormal blood pressure. So your typical antipsychotics such as your haloperidol, clopramazine will cause this, and also your atypical antipsychotics, so your clozapine, olanzapine, can cause this. So it's important, especially if you just started a patient on these drugs, to be aware of this. So this is just a picture, just to make you aware that it can present anywhere in the body. An adverse drug reaction isn't just a sudden rash from head to toe. It can present in a number of different ways. Importantly, I've seen in Liverpool exams before, adverse drug reactions, they're detected as a rule of 3. So if 30 people are exposed and 1 person has an adverse drug reaction, that is detected as a 1 in 10 status. So if 300 are exposed and 1 person suffers an adverse drug reaction, that is a 1 in 100. And then if 30,000 are exposed, it's 1 in 10,000. And then, quite interestingly, and I was quite shocked when I looked at this myself, the burden of adverse drug reactions is significantly high in primary care. So 25% of people coming to GPs are presenting with an adverse drug reaction to a new medication they may have started. So it's not this massive head-to-toe rash, life-threatening. It can present as much smaller, like less significant things as well. So I've done an example for you just so you can have an idea of what a type A drug reaction would look like. So warfarin is quite a common drug. Lots of patients in hospital will be on warfarin. It's a drug that reacts differently in different people. So it's heavily affected by people's diet, and also some genetic factors that some people may have can also affect how warfarin is absorbed in the body or metabolized in the body. So if you've got genetic factors CYP2C9 and VKORC1, you don't have to remember those, just be aware of them. Know that if you see that, it could be a reason. If they're saying something in an exam question, they're probably saying it for a reason. So genetic factors such as these and HLA genetic factors can cause increased or decreased absorption of warfarin in some patients. Warfarin is also a vitamin K antagonist. So it interferes with the hepatic carboxylation of vitamin K dependent coagulation factors. So factors 2, 7, 9 and 10. Warfarin then reduces these 4 factors, so the anticoagulant effect is then observed. So the obvious antidote to warfarin is vitamin K. Some symptoms you'd see, which would be an adverse drug reaction to someone who's newly started warfarin or on warfarin and started a new medication, maybe hemorrhage, so they will bleed. They might have red or brown urine. An exam favourite is coffee ground, blood in their stool, and also heavy bruising. So it's not just a tiny bruise on their hand or their arm, it's like the whole arm will be completely bruised. So some interactions to be aware of. So all of these drugs will increase your INR. So cimetidine, which is their H2RA, it's used for heartburn, so reflux and peptic ulcers, and omeprazole also used for reflux and peptic ulcers. This can increase the INR if the patient is also on warfarin. Heart drugs that people take for the heart, so amiodarone, which is an antiarrhythmic, that can increase your INR. An important thing to note as well, amiodarone, an adverse effect of amiodarone, it can cause a grey tinge to some patients. So they'll come in with like a blue-grey tinge to their skin, and that could be an adverse effect of amiodarone in some patients. Propranolol and simvastatin also increases the INR. SSRIs, so sertraline, that can increase your INR. Tramadol and other opioids can also increase your INR. So antifungals, so people who are on medication for athlete's foot, ringworm, thrush, cryptococcal meningitis, if they're also on warfarin, that can significantly increase that INR. Also co-trimoxazole, which is a combination of trimethoprim and methoxyl. I'm awful at pronouncing drugs names, sorry. You'll get the slides after. Is in a class of medications called sulfonamides. That can increase your INR. Important ones also is NSAIDs, allopurinol, and cranberry juice. That's also an exam favourite. If someone drinks a lot of cranberry juice, that can increase your INR. So other medications that can decrease your INR, so alcohol is a big one, carbamazine, the oral contraceptive pill, if a woman's on HRT as well, rifampicin, so if they're having treatment for TB, and St. John's wort as well. It's also really, really important when you're taking history from these patients to check if they're on any over-the-counter medication, because lots of patients won't disclose that they're taking St. John's wort because they don't think it's a medicine, but actually it's very, very important and can decrease your INR significantly. So a type B drug reaction, so Stevens-Johnson syndrome. So this is a rare and acute skin reaction where there is blistering mucosa. So you'd see that in an exam question. So it's the body is just full of blisters. It looks absolutely very, very painful and not nice at all. And this is nearly always caused by medications. So anyone on a medication can develop a Stevens-Johnson syndrome. It can affect all age groups and all races. It's slightly more common in females than males, and it's also 100 times more common in association with a HIV infection. So how does this present? So there's a timeline of events that could make you think this could be Stevens-Johnson syndrome. So firstly, it will develop within the first week of starting a new antibiotic, or within 2 months of starting a new anticonvulsant. So firstly, you'll get a prodromal illness, so an upper respiratory tract infection, or where you get flu-like symptoms. So these are a fever above 39 degrees, you'd get a sore throat, you can get really sore red eyes and almost look like you've got conjunctivitis in the eyes. You just get general aches and pains and feelings of fatigue as well. So that's like your prodromal bit. Then you get a really abrupt onset of like a red skin rash, which normally develops from the trunk and then extends to your face and your limbs. But it's important to know that this rarely affects the scalp, the palms of your hands or the soles of your feet. And the maximum extent of this rash is reached at 4 days. So the lesions seen on these patients will be macules, which is flat, red and diffuse measle-like spots, and purpuric spots, so really purple, smaller spots. You'd also notice diffuse erythema, so just red, painful, swollen all over, starting at the trunk and then moving towards the extremities. You could also get targetoid patches, so that's like, it almost looks like a dartboard, so you get a central red light dot, and then you'd almost have a ring of red around it. So these are called targetoid patterns. You'd also see blisters, and these would be flaccid blisters, so when you touch them, they'd be quite flaccid, they wouldn't be tense and they wouldn't be under a lot of pressure. So, and then the third part of this syndrome would be the blisters would then significantly merge towards each other and form almost sheets of skin detachment. So you'd have a layer of jelly-like fluid under the skin. Sorry if anyone is eating, that's not the nicest thing to be talking about. And you'd have like oozing nasty skin. So an also important thing to note here, the Nikolsky sign will be positive. So the Nikolsky sign is that when you rub these blisters, they would appear. So you rub the skin and then like a blister would just appear, and the skin can be rubbed away. So that would be a Nikolsky sign positive, which is also important to remember in your OSCEs as well. It sounds quite fancy if you say that. Also, just a warning, I've got some pictures on the next slide, so if you are a bit squeamish or you are eating, look away now. So this is Stevens-Johnson syndrome, so you can see that day 1, day 2 and day 3 is the worst. So you see mucosal involvement as well, so the lips will be involved. Day 5, day 9 and day 10 you're looking better. This is what the blisters can sort of start out like, so it's small macules. They've got the purpuric centre there as well, which will then form into blisters. And then this is obviously a Nikolsky sign positive, so this skin has been rubbed or touched and the top layer of the skin has been removed, and these blisters have burst as well. So that's just some pictures for you. I'll move on. Now the pictures have gone in case you looked away. So medications that commonly cause Stevens-Johnson syndrome are antibiotics. So that happens in 40% of all cases. I really struggle to remember drug names when it comes to exams. They all merge into one, and so I remember drugs by coming up with mnemonics. So I remember them by SNAP. So you've got sulfonamides, NSAIDs, allopurinol, penicillin and phenytoin. So those are the 5 most common drugs to cause Stevens-Johnson syndrome. And then your treatment would be fluid. That's really, really important. You're losing so much fluid through having all these blisters, they're bursting, and your skin has got such a big surface area, you're losing so much fluid. So it's so important to get these patients back on fluids. Give them steroids and also antibiotics. So toxic epidermal necrolysis. So this is an extreme form or variant of Stevens-Johnson syndrome. It's also caused by the SNAP drugs, but it involves the immune system. And the difference between this and Stevens-Johnson syndrome is toxic epidermal necrolysis is associated with HIV. So if the patient is already infected with HIV and they form a Stevens-Johnson syndrome type reaction, it will be most likely be toxic epidermal necrolysis. So a bit of pathophysiology for you. It induces the MHC 1 and 2 binding to the T cell, which causes Th1 to 17 and 22 response, so tissue damage in the skin. And it's also a immune checkpoint blockade. So symptoms, again, similarly to Stevens-Johnson syndrome, you get your loss of your epidermis, immense dehydration, and it's associated with HIV. The difference with this as well, you also give your patient fluids, steroids, antibiotics, but you also give them IVIG, which is a IV immunoglobulin. So some drug-drug interactions. So I always think it's really important to go back to the basics, so you understand the basics before you then can understand the drugs and how they react in the body. And you can get some drugs which are enzyme induction and some drugs which are enzyme inhibition. And there's a bunch of enzymes in the body called cytochrome P450, and these are essential for the production of cholesterol, steroids, prostacyclins, thromboxane A2, and they're also necessary for the detoxification of chemicals and metabolism of drugs. So in enzyme induction, if an enzyme is increased, so you're giving more enzyme, this will mean the substrate will be decreased, and there will be therefore more metabolites, there'll be more of the drug. If the enzymes are inhibited, so if these CYP450 enzymes aren't able to work, there'll be more substrate, the enzyme function will be reduced, and there'll be then less metabolite. So we've referenced this slide. The CYP450 inhibitors, so this means it inhibits the activity of CYP450. These are the sickfaces.com drugs, so I won't read them out because I don't want to bore you, but just remember it by sickfaces.com. And then the CYP450 induces, these are the crap GPS. Don't say GPs and CCT like I did, because it really upsets your CCT tutor. So remember it by crap GPS, not crap GPs. And just remember those drugs. These will reduce the anticoagulant action of warfarin and reduce the INR, for an example. Drugs associated with seizures. So again, I thought would just be good to know, to recognise in exams, is penicillin, carbopenum, nephapam, tramadol and quinolones. So I remember that by patients can never talk quietly. And drugs which require therapeutic monitoring is warfarin, gentamicin, methotrexate, cyclosporin, lithium, phenytoin, theophylline, insulin and digoxin. So I remember that by when grannies make cake, little people dig in. Finally, drugs causing hepatotoxicity. Remember that by vampires, so valproate, amiodarone, methotrexate, phenytoin, isoniazid, rifampicin, erythromycin, and simvastatin or sulfonamide. I'm not quite sure if you've had this lecture before, but there was a lecture series which Liverpool quite like and always popped up in exams, called 10 Ways to Kill a Patient, I believe, where they say 10 most common interactions or common mistakes made which causes adverse drug reactions in patients, and they love this, so there's always an exam question on this. So I've picked out a few examples and popped them on slides for you to remember. So methotrexate is used as an immunosuppressive, so it's used in rheumatoid arthritis, psoriasis, and in some chemotherapies. It's a folic acid antagonist, so it binds to DHFR and interrupts DNA synthesis, basically. And trimethoprim, so this is used for UTIs, it's used in treating MRSA, and it's also used in combination with sulfonamide, and which also inhibits the DHFR. So both these drugs are blocking your DHFR, and if you give them both to a patient, you will cause severe bone marrow depression and neutropenic sepsis. This is a big no-no, just never do this. If you see this in exam questions, see this as a red flag straight away. They can't be prescribed together. Example number 2, so azathioprine is also an immunosuppressant. It's used in ulcerative colitis, in Crohn's, and also rheumatoid arthritis, and it's metabolized to 6-MP. Allopurinol is prescribed in patients who have gout or high uric acid levels, and it also it inhibits xanthine oxidase. So your allopurinol inhibits xanthine oxidase, which increases the 6-MP levels, and azathioprine is broken down to 6-MP, so levels rise even further, and there's nothing to break it down, so you've just got so high levels of 6-MP, and again you'll get severe bone marrow depression, and that's where you'll see your blood dyscrasias. So don't ever prescribe these two together. So example 3, so quite common, this example is patients who are on warfarin and a statin. So like I was saying before, warfarin is an anticoagulant, and statins lower the cholesterol in the blood. And both of these are metabolized by the CYP450 enzyme. And then clarithromycin or erythromycin is really, really common. It is prescribed for patients who are suffering pneumonia or lower respiratory tract infections. And these are CYP450 inhibitors. So your erythromycin will inhibit the CYP450, causing an increase in warfarin and statin, in statin availability, and these will be due to a reduced metabolism. So both are increasing your INR, and this can cause severe bleeding and rhabdomyolysis. Which is rhabdomyolysis is a condition which damaged muscle fibers are broken down and they then enter the bloodstream. Again, never prescribe these together. Big no-no. Example 4. So beta blockers such as metoprolol. These work on your SA node and they reduce your heart rate. And CCBs are your cardio-selective CCBs, so verapamil and diltiazem. These work on your L-type calcium channels, and they block the AV node conduction. So you're blocking the SA node and you're blocking the AV node. You're just causing severe bradycardia, really, really low heart rate, and you can cause patient cardiac arrest. So never prescribe a beta blocker and a CCB, a cardio-selective CCB together. Non-cardio-selective CCBs and beta blockers can be prescribed together, but if it's cardio-selective, you can't prescribe it with a beta blocker. Couple of the last examples now. So lithium, which is a mood stabilizer, you'll see that in psych quite a lot. And thiazide diuretics. So lithium reabsorption is dependent on sodium. Sodium is reabsorbed and lithium is excreted. Excretion is dependent on the GFR, and high GFR will equal an increased lithium excretion. But thiazide diuretics reduce patients who've got edema, they reduce it by decreasing the sodium reabsorption and encourage water loss, but these will also reduce the GFR. So an increase in lithium reabsorption and due to the increased sodium excretion, and these will obviously increase the GFR, and it will reduce the lithium excretion. So you're causing a low GFR and less excretion of the lithium, so your levels of lithium will be so high and to a toxic level, and it will present in patients with confusion. These patients will be really, really confused and never prescribe lithium with thiazide diuretics. And my last example, so it's just carbopenum. So these are similar to penicillins. They've both got the beta-lactam ring, and this causes cross-reactivity with penicillin allergic patients, and this can present with a hypertensive crisis. So just be aware of prescribing carbapenems with people who've got a penicillin allergy. So I've got some previous exam questions. Is everyone okay if I crack on with the exam questions, or has anyone got any questions for me as I go? I haven't looked at the chat. Is that okay?
There were a few questions that I wrote down on the way. Do you want to take them now or at the end?
Should we do the exam questions now, and then I might answer the questions in the questions almost, and then we'll come back to the questions. Is that all right?
Yeah, sure.
Oh, fab. Okay, so I've only got 5 questions, and these are all taken from Liverpool, Uni of Liverpool past papers. This was in a finals paper. So a 40-year-old woman with rheumatoid arthritis attends her regular outpatient appointment. She mentions that she's feeling unwell and feverish. She's just finished a short course of antibiotics for a urinary tract infection, and her regular medications include methotrexate, naproxen, paracetamol, and folic acid. So I'll let you read her blood count because I won't bore you by reading lots of levels. And then I want you to, after looking at that blood count, decide what the most likely explanation for these lab results are. So A, an allergic drug reaction, B, anemia of chronic disease, C, bone marrow suppression, D, gastrointestinal bleed, or E, viral infection. I'll give you a minute or so.
So quite a lot of people are answering in the chat. They're saying C.
C.
Someone said C, but it could be E as well.
Okay. Fab, we'll go on to the answer. Yeah, so if you said C, that's right, it's bone marrow suppression. So if we go back to, I think I had it in my example. Yeah, so methotrexate and trimethoprim will cause severe bone marrow depression or suppression. Question number 2. A 62-year-old man has recurrent palpitations. He has a history of angina, poorly controlled asthma, esophageal reflux, and osteoarthritis. He's got a pulse rate of 135 BPM, BPM, yeah, sorry, and a blood pressure of 155/88. His ECG shows atrial fibrillation. Which drug is contraindicated in this situation? I can see a lot of you answering A. So we'll move on to the answer. Yeah, well done, everyone who said A. So bisoprolol. So you've got bisoprolol is a beta blocker, and then you've got he's got palpitations, he's got poorly controlled asthma, so you don't prescribe bisoprolol in people who have got asthma. Question number 3. A 48-year-old woman with rheumatoid arthritis on methotrexate is commenced on a therapy for urinary tract infection. 4 days later, she becomes unwell with a high fever and diagnosis of neutropenic sepsis is made. What therapy was commenced that caused this drug interaction? Lots of people are answering D. Move on to the answer. So yeah, everyone's doing really well on this quiz. Well done. So trimethoprim, trimethoprim and methotrexate can cause neutropenic sepsis and severe bone marrow suppression. So the most likely mechanism underlying the interaction between warfarin and erythromycin is a couple of people have said A. Any more? Yeah. So moving on to the answers. Yeah, you're right, A. So erythromycin is obviously an enzyme inhibitor of CYP450. So it's other drugs which are metabolized by this enzyme. So obviously warfarin in this case is metabolized by that enzyme. It won't be metabolized as fast as usual, so the levels will build up. It's also important to note that warfarin and erythromycin can still be co-prescribed, but you need to very, very, very closely monitor the INR, and lots of people just don't prescribe them together because the monitoring of the INR is so you've got to monitor it really, really closely, basically. And the last question. So you've got a 60-year-old woman with a severe drug-induced reaction on both lower limbs, with few lesions elsewhere, in addition to mucosal involvement of the mouth of 2 days duration. She was taking sulfonamide, and the onset of the rash was within 24 hours of taking the drug. The rash was had bilateral symmetry bullae on the background of the erythematous macules and patches, in addition to erosions and peeling. So which of these drugs is not a trigger of Stevens-Johnson syndrome? So a couple of people are answering D. Any more? No, okay, we'll go on to the answer. Yeah, so erythromycin. So a little bit of like exam technique. So always looking for mucosal involvement, that can suggest Stevens-Johnson syndrome, erosions and peelings, and also the onset of rash within 48 hours as well. That's quite an important factor in this case. So obviously, if you remember your SNAP drugs, erythromycin isn't part of those. So that is the last of the quiz. So I've got my last slide. So thank you everyone for listening. I've put my email there if you've got any questions at all, any questions about anything I've said today, or even like any general questions, just give me an email, even about intercalating or the MRES, doing dementia care, anything, send me an email. I'm more than happy to reply.